Hello, everybody. So today we're going to be discussing the adult immunization schedule from the CDC. So everyone should have the quick guide for the adult immunizations. So we'll go quickly over that, and then we'll go through each one individually. So basically, these guidelines were approved in October 2011 by the Advisory Committee on Immunization Practices, or the ACIP. There are some changes that were made from the 2011 guidelines, so we'll go over that as well. So just a brief overview of the quick guide. So basically, the first one, influenza, as we all know, is now recommended for all adults, one dose annually. The next one is the tetanus, diphtheria, pertussis, or TD or Tdap. One dose should be substituted for one of the TD boosters. And then the far right for the over the age of 65 group. So basically, the Tdap is recommended for those who are exposed to young children less than 12 months. The white indicates no recommendation. The next line, varicella, 2 doses are recommended for all age groups. The next line is the HPV for females, 3 doses for females less than the age of 26. Next line for males, typically for males, the ages of 19 to 21, it's recommended. Purple basically means it's recommended for certain groups of patients with risk factors depending on their medical, occupational, lifestyle risk factors. And we'll go over that more specifically for that group. The Zoster vaccine is recommended for patients age 60 and over. The MMR for patients between the ages of 18 in the 50s as well. And that is recommended for certain age groups with certain risk factors. Pneumococcal vaccine is recommended for adults over the age of 65. Less than 65 is for groups with certain risk factors, which we'll go over as well. And that goes for hepatitis A and hepatitis B as well. For the influenza, we basically mentioned a 1 dose of the trivalent injectable virus annually for all groups. The next one for Tdap, we've mentioned that the Tdap should be a substitution for one of the Q10-year boost, TD boost. The next one, the varicella vaccine, it's a live virus vaccine, so it's contraindicated for pregnant patients, HIV patients who are immunosuppressed, meaning a CD4 count of less than 200. The next line, HPV, we mentioned earlier for patients less than age 26, and it's 3 doses. Next one, Zoster, contraindicated in pregnancy, and immunosuppressed patients, HIV patients less than CD4 count of 200. MMR also not recommended for pregnant patients, HIV patients with a CD4 count less than 200. So the influenza vaccine, every year the FDA, WHO, and the CDC and other institutions study the virus samples from around the world, and they identify the viruses that are most likely to cause illness during the upcoming influenza season. So the upcoming season, in February of this year, WHO recommended that the Northern Hemisphere for 2012-2013 seasonal influenza vaccine contain the trivalent Influenza A California 7 2009 H1N1, which is the same one as the last season. The last two are somewhat different. It's the Victoria 361 2011 H3N2, and then the last one is the B, which is the 2010 like virus. So the annual trivalent meaning 3 components, inactivated virus, there's 2 of them. There's the TIV, which is recommended for everyone above the age of 6 months. Healthy, non-pregnant adults younger than age 50 without any medical risk factors can actually receive the live attenuated. It's intranasal. It's the Flumis, or they can receive the inactivated injectable TIV. Healthcare workers who will be taking care of severely immunosuppressed patients are actually not recommended to get the live virus vaccine. Adults above the age of 65 have an option of receiving the standard TIV or the high Fluzone vaccine. So just some information about the Fluzone High-Dose. So elderly patients have a weakened immune system, and they're likely to have a weaker response to the vaccine. So the Fluzone High-Dose vaccine contains about 4 times more than the standard. It was licensed for the 2011-2012 influenza season. Data indicate that the 65-year-old and older patients have a higher immune response to the high-dose Fluzone vaccine compared to the standard. There's really no evidence to actually show that they have a greater protection, so that the CDC and the ACIP don't recommend either one or the other. So it's up to your discretion. It's just an option, basically. So contraindications, anaphylaxis, and that's going to be a contraindications to every one of the vaccines that I'll be mentioning. Precautions, moderate to severe acute illness with or without fever. And a little bit controversial, but a patient with a history of Guillain-Barré Syndrome, especially if it was within 6 weeks of a previous influenza vaccine, should not receive the flu vaccine. The live attenuated, again, anaphylaxis to the vaccine or to eggs, immunosuppression, any sort of chronic medical condition, including diabetes, asthma, heart disease or kidney disease, and also pregnancy. Precautions, again, any moderate or severe illness with or without fever, GBS within 6 weeks of the vaccine previously, or patients on antivirals, including amantadine, zanamivir, and oseltamivir, 48 hours before the vaccination. So the Tdap, we've mentioned earlier, one-time dose is recommended for patients, especially those in contact with young children less than 12 months of age. In 2011, ACIP, in 2011, recommended for postpartum vaccination was preferred at that time. However, after 2011, it's recommended that women who are pregnant with gestation after 20 weeks should receive the vaccine. And if that did not happen after 20 weeks, then they should receive it after delivery. So other special recommendations are pregnant women, as I mentioned, adults regardless of age because of any contacts with infants, and also healthcare workers as well. Adults, if with unknown or incomplete history of completing their series, should again get the Tdap as a substitution and then continue the series of TD. Patients who have not been vaccinated, they should receive 2 doses at least 4 weeks apart, and then as I mentioned, one of them should be a Tdap. If they had incomplete vaccination, basically less than 3 doses, you just continue the remaining missing doses. Contraindications, anaphylaxis. For Tdap, any history of encephalopathy that's not attributable to anything else other than the Tdap. Precautions, moderate or severe acute illness with or without fever. Any sort of hypersensitivity reaction to previous dose of tetanus or diphtheria toxoid containing vaccine. Patients who've had neurologic disorders, seizures, or encephalopathy should also take precautions when taking this vaccination. Varicella, all adults who have no immunity to varicella should be immunized with at least with 2 doses of a single antigen varicella, and the second dose should be given to any adult who have received one in the past. Special considerations are for patients with severe disease, including or families in contact with patients who are immunocompromised. Residents or staff members to correctional institutions, college students, military personnel, adolescents or adults in households with children, non-pregnant women who are of childbearing age, and international travelers. Pregnant women should be assessed for evidence of varicella immunity, and those without immunity should receive the first dose after pregnancy and before being discharged after delivery. The second dose is administered about 4 to 8 weeks after the first dose. So evidence of immunity is basically you have to have documentation of 2 doses of the varicella vaccine at least 4 weeks apart. People who were born before 1980 are assumed to be immunized against varicella, except for healthcare workers and pregnant women. Being born before 1980 is not considered immunity if you're pregnant or if you're a healthcare worker. Having had a history based on diagnosis that's verified by a healthcare worker, that's considered immunity. Any patient with a history of varicella zoster based on diagnosis that's verified by a healthcare worker or laboratory evidence of immunity. Contraindications are anaphylaxis, any known severe immunodeficiency from hematologic or solid tumors, patients on chemotherapy, congenital immunodeficiency, HIV, pregnancy. Precautions, patients who've received antibody-containing blood products, basically IVIG, for example, moderate to severe illness with or without fever, patients on antiviral therapy, acyclovir, famciclovir, or valciclovir 24 hours prior to the vaccination. Actually, you should delay vaccination. So the HPV virus, there are two vaccines that are licensed. There's the bivalent HPV vaccine, which contains the HPV type 16-18, which cause about 70% or more of the cervical cancers. The quadrivalent HPV Gardasil, it contains 16-18 and also 6 and 11, which cause most of the 90% of genital warts. For females, it's recommended that they receive either HPV 2 or 4. It's a 3-dose series for patients between the age of 11 and 12. If not received between 11 and 12, it can be received between 13 and 26 if they were not vaccinated. For males, only the HPV 4, not the bivalent, is recommended. It's also a 3-dose series recommended for ages 11 and 12. And if it was not received between age of 11 and 12, then between 13 and 21, if not yet vaccinated. And then if not, then between 22 and 26 is acceptable as well. So HPV is not live. Anyone, whether immunocompromised or not, can receive the HPV vaccine. It's recommended for immunocompromised patients through the age of 26, and the immune response may actually be lower in these patients, but it's still recommended. Men who have sex with men may benefit as well because it may prevent condyloma or anal cancer. So it's recommended for these patients as well through the age of 26. And also, I put at the bottom, healthcare workers, it's an option for them too. So ideally, the vaccine should be administered before potential exposure. So obviously, the younger the patient, the more benefit, but it's still recommended if the patient missed these doses at the age of 11 and 12, as we mentioned before. Patients with a history of genital warts, they should still receive the vaccine, as well as if they've had an abnormal pap test or positive HPV DNA test, they should still receive the HPV vaccine. So contraindications, anaphylaxis, precautions, it's pretty much the same thing as we've mentioned before. Moderate to severe illness with or without fever, and pregnancy. So Zoster vaccination, a single dose is recommended for patients 60 years and above. The vaccine is actually licensed by the FDA for patients above 50, but the ACIP recommend to begin at the age of 60. Patients with chronic medical conditions can also be vaccinated unless there's some contraindication, such as being pregnant or having a severe immunodeficiency. Healthcare workers should also be vaccinated if they meet the age criteria. Contraindications, anaphylaxis, immunodeficiency in pregnancy. Precautions are moderate to severe illness, receipt of acyclovir, femvir, and valciclovir 24 hours before. If possible, you should avoid these antiviral drugs for at least 14 days after the vaccine. The MMR, adults born before 1957 are considered immune. Adults born in 1957 or later should have documentation of one or more of the MMR vaccine, unless they have some medical contraindication to the vaccine. For rubella, having had a documentation history of rubella is not considered immunity. For unvaccinated healthcare workers before 1957 who have no evidence of the measles, mumps, or rubella immunity, or lab confirmation should receive vaccination with 2 doses of MMR at the appropriate intervals, which we'll mention later. So for the measles component, a second dose of the MMR should be administered 28 days after the first one, and that's recommended for adults who are students in post-secondary educational institutions, a healthcare worker, or international travelers. Persons who have received the inactivated measles vaccine or measles vaccine of unknown type should be revaccinated with 2 doses of the MMR vaccine. Women of childbearing age, regardless of their date of birth, rubella immunity should be determined. Whether or not they've had a previous history, they should still be tested for rubella immunity. And if there's no evidence and they're not pregnant, then they should be vaccinated. Women who do not have evidence of immunity and they're pregnant, they should actually receive the MMR vaccine after delivery. Contraindications, anaphylaxis, immunodeficiency in pregnancy, precautions, moderate to severe illness, a recent receipt of antibody containing blood products, IVIG for example, thrombocytopenia, thrombocytopenic purpura, and also there's some evidence that the MMR actually decreases tuberculin test reactivity. So that's another precaution that should be taken if the patient is going to need a tuberculin test. The 23-valent pneumococcal polysaccharide vaccine. So the recommendations are for patients age 65 or older without a history of previous vaccination. Adults younger than 65 if they have chronic medical conditions including COPD, emphysema, asthma, chronic cardiovascular disease, diabetes, chronic liver disease, alcoholism, functional or anatomic asplenia, including sickle cell disease or some other hemoglobinopathy, congenital or acquired asplenia or splenic dysfunction or splenectomy. If an elective splenectomy is planned, patients should be vaccinated at least 2 weeks prior. Residents in nursing homes or those living in long-term care facilities, smokers, and HIV-positive patients. Patients on chemotherapy or any other immunosuppressive therapy, if that's being considered, they should actually delay the vaccine for at least 2 weeks after. This, I put a question mark by that, but which I wasn't aware that American Indian and Alaskan Natives, it's not recommended, and I'm not sure what the reason for that is. But I'm sorry.
It used to be recommended in those 2 groups, but
Right.
there's really no indication because you're treating comorbidity issue, not
Okay.
ethnicity issue.
Okay.
Unless there's an outbreak in a patient or something.
Right.
But the reason you don't, the reason you they talk about America and Alaska because they have specific genetic the term
Okay.
immunodeficiency.
Oh, I see.
Pneumococcal. So for children, they have a different schedule of pneumococcal vaccine, different that they have kids. The same
Okay.
also for RSV. So
Okay.
they may have they have boosters with the polysaccharide after they have completed the standard childhood
Okay.
vaccination because genetic predisposition to pneumococcal, Haemophilus influenza despite of vaccination, and RSV.
Okay.
They start the pediatricians in the area that in America and Alaska they start to give prophylaxis for patients who are born premature for RSV even before of the season because also the season there they live is prolonged. So
Okay.
it's an immunological predisposition.
Okay. So revaccination, there's a one-time revaccination 5 years after the first dose is recommended for patients 19 to 64 if they have chronic renal failure or nephrotic syndrome, functional or anatomic asplenia like sickle cell disease, for example, or splenectomy, or immunocompromised patients. Patients who have received the pneumococcal vaccine before the age of 65, they should receive it after the age of 65, one-time dose, and at least 5 years prior to the last dose. And then after the age of 65, there's no further doses needed. Contraindication is pretty much the same. The meningococcal vaccine, there are two general types. We have the conjugate vaccine, which includes the Menactra and the Menveo, and it contains capsular polysaccharide antigen, the ACYW135, which is conjugated to the diphtheria toxoid, and the CRM195 for the Menveo. The polysaccharide vaccines, the Menimmune for adults and children older than 2 years, it contains a capsular polysaccharide, same serogroups. The B meningococcus, although it's one of the most common or the most common serotype, it there's no effective vaccine preparation licensed to use for use. It's very poor immunogen in humans, and probably it's due to similarity to its immunochemical structure to human intracellular adhesion molecules. Um, the administration of this vaccine is 2 doses of the conjugate vaccine, the quadrivalent, at least 2 months apart, and including for patients with HIV and those with functional asplenia or complement deficiencies. Administer a single dose to microbiologists as well. Microbiologists routinely exposed to Neisseria meningitis, military recruits, and travelers to countries with high endemicity. First-year college students up through the age of 21 who are living in residence halls, they should also be vaccinated if they have not received a dose after their 16th birthday. The Menactra is preferred for adults who are 55 years or younger, and the Menimmune is preferred for adults 56 years and older. Revaccination, we mentioned, every 5 years is recommended for adults previously vaccinated with either MCV or MPSVA who remain at increased risk. And that includes patients with anatomic or functional asplenia or persistent complement deficiencies. Contraindications are the same. Hepatitis A vaccinations are indicated for men who have sex with men, IV drug users, patients who, or not patients, I'm sorry, healthcare workers who work with hepatitis A infected primates, or hepatitis A research laboratory settings, chronic liver disease, or travelers to high endemic countries. Unvaccinated persons who anticipate close personal contacts should be vaccinated. The first dose of the 2-dose Hep A series is administered 2 or more weeks prior to arrival. If someone is planning on adopting a child from a high endemic country. So the vaccine is administered at 0 and then 6 to 12 months. That's the Havrix, or 0, 6 to 18 months. That's the Vacta. If the combined Hep A and Hep B vaccine is used, the Twinrix should be administered at 3 doses at 0, 1, and 6 months, or you can do the 4-dose schedule, which is days 0, 7, and 21 to 30, and after that a booster at month 12. Contraindications are the same, and the precautions, pregnancy is one. Hepatitis B vaccine, sexually active persons not in a long-term mutually monogamous relationship because of the risk factors, they should be vaccinated. Patients who are seeking evaluation or treatment in STD clinic, or IV drug users, or men who have sex with men. Healthcare workers, public safety workers who are exposed to blood or other infectious body fluids, diabetics younger than 60 years, as soon after their diagnosis, should be vaccinated. End-stage renal disease patients, those on dialysis, chronic liver disease, HIV, household contacts, international travelers to countries with high endemicity. Adults in STD treatment facilities, HIV testing treatment facilities, drug abuse treatment facilities, healthcare workers, MSM correctional facilities, dialysis patients. And so for missing doses, basically you just complete the 3-dose series. The second dose is administered a month after the first one, and then the second dose is at least 4 months after the first dose. And we've mentioned the twin risks. So Hep B, one dose is administered for patients with sickle cell disease, leukemia, HIV patients, those with anatomic or functional asplenia, if they've not received the Hep B vaccine. And I think that's the last one. So safety of vaccines. So thimerosal is a mercury-containing preservative that's used in some vaccines and other products since the 1930s. In 2001, it was either removed or reduced to trace amounts in all childhood vaccines except influenza. The MMR, varicella, and inactivated polio and pneumococcal vaccines do not contain thimerosal. The influenza vaccine, the injectable trivalent, currently available in both the thimerosal containing and the thimerosal free versions. So autism and thimerosal, it's estimated that about 1 to 88 children have autism, which I thought is high, but that's what they quoted in the CDC, which is higher than the 90s. And evidence, however, does not support a relationship between vaccines containing thimerosal and autism rates in children. The Institute of Medicine has recently conducted a thorough review of the evidence on vaccines and healthcare adverse events. They released a report in August last year on 8 vaccines and found that vaccines are generally safe and don't lead to serious adverse events. Thimerosal can cause minor reactions, but there's really no evidence to show that it leads to autism. So thimerosal content in vaccines according to the US FDA. This is just a list just to show the content of pretty much all the vaccines that we administer. So anthrax, DTaP, DT, and TD, either 0 or very minuscule amount of thimerosal. The Tdap for adults, 0, Hib 0, Hepatitis B, A, 0, polio, 0, and influenza, it's depending on the manufacturer, it's either 0 or very minuscule amounts. And then the live is 0 as well. Japanese encephalitis is pretty low, 0.007. MMR is 0. The meningococcal is 0.01. Pneumococcal, rabies, smallpox, typhoid have no thimerosal. Post-vaccination syncope. 2005 syncope has been increasingly reported after vaccination, and that has resulted in some serious injuries. It's more common in adolescents between the ages of 11 and 18 who have received the HPV, and that's the most common one. And others include the MCV, the meningococcal, and Tdap. The ACIP recommend that providers observe patients about 15 minutes after receiving a vaccine, and if syncope develops, they should be observed until their symptoms have resolved. Guillain-Barré Syndrome is most commonly associated with diarrhea from Campylobacter and rarely with influenza. Most studies conclude that there is no link between the influenza vaccine and the GBS. As of February of 2008, there have been about 26 cases of GBS occurring within 6 weeks of the MCV meningo vaccine, out of the total of 15 million doses that have been distributed. So this may suggest a small increased risk of GBS, but the CDC is still not able to determine with certainty that Menactra increases the risk of GBS in patients who have received the vaccine. So the CDC recommends that adolescents and their caregivers actually be informed that this is being investigated during the consent process, but that the vaccine is generally safe and they should be vaccinated. So simultaneous vaccine administration, the live attenuated influenza, the MMR, and varicella vaccines can be administered on the same day. And if not done on the same day, these live vaccines should be separated by at least 28 days. Okay.
Weird. Take care of all
Yeah.
these together, or you
I
have
know.
separate